Okay, everyone, we're going to get started. Thank you for joining today's Insights. The topic is reimbursing chronic care management. Shauna Matonis will be leading. She works with Cork. She's the Senior Project Specialist and Regional Vice President of the Northeast. Shauna, we are ready when you are.
Thank you, Sarah. Give me 1 second here. I'm going to go ahead and share my desktop so that everyone can see the presentation. Okay, so just a couple of housekeeping items. I just wanted to let you know that the chat window is out there should you have some questions along the way. Also, if you wouldn't mind making sure that you're on mute during the presentation, and then we'll open it up for some questions at the end. I wanted to thank everybody for joining on this Wednesday afternoon. I know that we have busy days, but the topic for today we thought was important just to kind of disseminate the information and get it out there for those of you who are interested in kind of the early stages of the details that have been released on the reimbursement for the chronic care management. So, and I apologize, give me 1 second here. There we go. Okay. So the concept, of course, has always been simple. It's reduce costs and improve health care. And a lot of the things that we're seeing come down from CMS with meaningful use and some of the other things that have been passed along really does point to the fact that costs are increasing and they're trying to bring the focus back around to improving the care for the patients and meanwhile adjusting the costs. So that being said, chronic disease management is a huge burden in the healthcare community. And that being said, it's been proven that the care management of chronic disease accomplishes a couple of different things. But with that, it's never been reimbursed before. It's always been an unpopular thing in healthcare, especially among primary care physicians, simply because, number one, there was a lack of payment. If your patient came into the office and they were seen and you were billing out your evaluation and management codes, any work that the provider was doing or the staff was doing afterwards was always included as part of that. In addition to that, there were costs involved with that staff or the staff time, physicians staying late. Technology was a challenge, it was a hurdle. And then additionally, regardless of whether it was providers or staff, time was always an indirect cost that was associated. And then, of course, we had some software limitations. Practice management systems weren't equipped or ready to deal with some of the care management pieces. And so we find that a lot of the software has kind of implemented the care management pieces more recently just because of the turn of events. But I think it sends a very clear message to those of us in healthcare, especially primary care, that CMS believes strongly that managing the disease or chronic disease is effective, and because it's effective in reducing costs and all of the actual overall care for the patient, they've decided to go ahead and reimburse the primary care physicians, any physician actually outside of some of the guidelines that I'll show you later, to manage these patients better, reduce the chronic disease, and start seeing some of the positive impacts that it can have on our patient populations. One of the staggering things that CMS has acknowledged is that 75% of our healthcare spending is directly related to chronic conditions, and if you think about that 75%, that is staggering. So I think that it was an issue that can no longer be ignored. It sends a very clear message that if it's that big of an issue in the community, in our direct populations and as a nation as a whole, that these chronic disease patients need to drive what's going on in the future. So that being said, one of the acronyms, I know that we're flooded by acronyms every day, but the new one is the NFQF, which is your non-face-to-face. And a lot of the things that you see on the list below are things that we've been doing in primary care. We've been doing it anywhere that really the care management has been taking place, and it's been under-recognized, undervalued, and therefore not reimbursed. So answering the phone messages when the patients are calling, or answering the electronic messages if you were that far in the technology, responding to the labs or consultation recommendations. All of those things are things that were going on, but were being included in the evaluation and management that we were billing. So the policy that they've released says, guess what? It's no longer bundled. We really do want to fix the problem of our chronic disease. So when we're billing for evaluation and management, or an annual wellness visit, or even our Welcome to Medicare visits, they are now going to consider separate payment for the non-face-to-face care management services. Obviously, it has to be a Medicare beneficiary, but I'm sure that we're going to see some of the other payers follow suit very soon. Now, there are cases where this policy says that it is bundled, and those were going to be your home health, your hospice, your transitional care, and your nursing home. Those are the 4 caveats to that bundled piece. Otherwise, it's no longer a bundled service. The criteria, again, it must be a Medicare patient. They must be expected to live 12 months or until death. And they have to have more than one significant chronic condition, meaning 2 or more. Those are the pieces that they've handed down. It talks about what they will consider as part of the payment. And so I've put together a little piece, and keep in mind that this is obviously in the very early stages of this being rolled out. Again, it's effective January 1st, but we're probably going to see some additional caveats come down the way. But as far as the reimbursement goes, it's going to be roughly $42. I say roughly because I think that they predicted their payment would be $41.97. However, the final fee schedule I didn't have in hand to make sure that the figure was still true and accurate. Kind of surprising is that it is going to be subject to a co-payment. So I don't know about those of you on the other end of this call, but I'm going to imagine that that's going to be a challenge for those of us where the physician or the staff is doing work after hours, non-face-to-face, patient has no idea that we're doing the work, and then we're going to be billing them for a co-pay. So please keep that in mind. The reimbursement is going to be time-based. It's based on 20-minute intervals. And in order to get the bill sent over, or the claim sent over to the payer, there's going to be a HCPCS code that's going to be used. That code has not yet been released. It's going to be coming down the way in November, so very soon here. As far as the submission goes, the way that this works is for each of your qualifying patients, you can bill 1 per month per qualified patient. And the 4 caveats to that is it must relate to any of these 4 components of the care plan. And then we love the requirements that always comes along with getting reimbursed. So I've kind of outlined for you what the requirements are going to be to get reimbursed for the non-face-to-face care. The first part of that is the documentation and the record. And I'm sure that we're all thinking, well, yeah, that's to be expected. However, please keep in mind that because this is a time-based code, that the documentation must document the time and the service provided. It also requires that you have a written agreement that the electronic communication of the patient's information is part of the care. So whatever policies you have in effect, you may want to go ahead and make sure that your policies include that when your patient's signing consent forms. And then, of course, you need to have information about the availability of the services from the practitioner. And then, of course, you're going to want a written or an electronic copy of the care plan that's provided to the beneficiary, as well as recorded into the EHR. There were some stipulations regarding the services and being reimbursed, and there probably will be some additional stipulations that come down the way. Those that have been outlined so far involve the continuity of care with a clinician or practice. So keep in mind that if you're a practice that has 6 or 7 different providers, that continuity of care is that this patient's establishing with one provider that's going to be managing that care along the way and managing the care plan team. It also asks that the care management provide the following: the systematic assessment of medical, functional, and psychosocial needs, a system-based approach for the timely delivery of preventative services, meaning that you're following up and making sure that the patients are scheduling for their annual preventative care, your medication reconciliation, which most of us are already doing for meaningful use. But the caveat here is that it's for both prescription and non-prescription. I think that's important to note. Of course, the review of the interactions and adherence. And then, of course, the creation of an updatable patient-centered plan. The care plan has to be very well documented, and it must, the provider must be managing the care transitions. The other caveat is that both the provider as well as the patient need to have 24/7 access to an EHR. And then, of course, you need to provide opportunities for the patient to provider communication via the telephone or non-face-to-face messaging. So your patient portals are going to be very important. So I've outlined some of the things that I think are important when you determine about where you're going to begin if you're going to be reaching out to get the reimbursement for your chronic care management. The first one is to identify the patients that actually meet your criteria. So you're going to need to identify your patients who have 2 or more chronic conditions. And then, of course, the communication. And if you think about all of the stipulations and the requirements and the caveats, you're going to need to, number one, communicate with your patients to get them enrolled in your process. And number 2, you're going to need to make your patients aware that the co-payments do apply. And then, of course, you're going to want to plan as far as how your care management team is communicating the care for your patient. You're going to want to make sure that you have written protocols that go along with these processes. And again, you have to identify the appropriate staff who makes up that clinical care management team. And one of the things that's recommended is that you pursue a PCMH designation. I will tell you that the stipulations right now do not say that you have to be designated as a PCMH, but it is coming. Everything that I've heard says that this is going to be something that becomes mandatory down the road. And then, of course, you need to establish your strategy. So I'd like to open it up and see if there are any questions about any of the items that I've just kind of thrown out there. I know that it's a lot to take in. Of course, these slides are going to be available. The presentation is going to be available after the fact in case you wanted to kind of look at some of the points that we've discussed here in the call. But I've opened up the chat window. If anyone has any questions that they'd like to send my direction, I'm happy to take a look and see if we can get those answers for you.
And I have unmuted everyone, so just so you know.
I can't imagine that there aren't any questions.
Hey, hear me?
Eva, go ahead. Did you have a question?
No.
Okay. Anyone else?
Hi, Shauna. Can I ask you a question?
Sure, absolutely.
Now, this is for the Medicare. We are attended medical home.
Hold on, sorry. I'm sorry to interrupt. There are a couple people who are not on mute, and therefore it's hard to hear asking this question. So if you could just check your phone and make sure that you're on mute, that'd be really great. Thank you.
Hi, Shauna. So we are a pediatric practice with patient-centered medical home designation via the NCQA. And since we have all Medicaid patients here with chronic multiple conditions, many of them, this is being rolled out by Medicare. Would we be able to pursue this as well, the non-face-to-face reimbursement for chronic?
I will tell you that since this is coming down from CMS, I would imagine that the Medicaid payers are also going to follow suit. However, right now it does specify, first of all, let me say this, children are eligible to be managed for the chronic disease management. So I would reach out to your Medicaid plans and inquire with them as to whether they're going to also make this effective January 1st, or if it's soon to follow.
Okay, we'll do that. Thank you for answering that.
Yeah, absolutely. Anyone else? Okay, well, I appreciate everyone attending today. Please know that you are more than welcome to reach out to me afterwards. I have my email address here at the end of the presentation. If you'd like to take down that email address, you're welcome to send an email along if you think of questions later. Don't
Shauna?
hesitate. Yes.
Hi, I'm sorry, I have a question. I put it in the chat, but I don't know if you saw it or not.
You know what, I didn't see anything come up through the chat, but go ahead.
Okay. We're a consultative cardiovascular practice, and we don't do any primary care. We're not patient-centered medical home or anything. Do you think that this could be something that would work for us? We do have a patient portal, but like...
Are you currently doing, so you're currently managing the chronic disease, and there's nothing, they have not carved out stating that certain types of providers are excluded. It includes any provider that's managing chronic disease. So if you have the volume and you have a good process in place, I absolutely think that you should pursue it.
Okay, but I mean right now, for like CHF patients, those are patients where I could see where this would be applicable. They're just coming in for an office visit every month if they need to. So why would we do this over that?
You get paid for both your E&M in addition to the reimbursement for the non-face-to-face. So if you are
this is
bringing
billing
your
out for the telephone calls and all those kinds of things?
This is different. This is different than the telemedicine. What the chronic care management is intended for is it's for your physician to follow the care management plan. And so if your physician is involved in that care management piece, then absolutely he can bill not only for his E&M once a month, but he can also bill for any work that would be involved in the care management piece as long as it's documented and, of course, all the requirements are met. He can bill also for non-face-to-face. So if he's on the phone and he's managing that care with referrals and he's managing the care, you know, there's a list of those things that are encompassed under that care management piece. If he's doing that work, I recommend billing it in addition to your E&M. The patient can come in 3 times and you're billing your E&M. He can still submit that once a month.
Okay. Okay. Thank you.
You're absolutely welcome. Anyone else?
Shauna.
Yes.
This is Pam Collins. I'm in a primary care practice, and what I hear you talking about is the provider making these calls. We were looking at more of case management, of the care managers making the calls.
Do you have a care management team in place, it sounds like?
Yes, yes. I'm the care coordinator.
Okay.
And we are patient-centered medical home, level 3.
Yeah, so you would qualify.
Okay. Okay. So it doesn't have to be just
Go ahead.
Well, I'm an RN, and I'm the care coordinator.
You know what? If you wouldn't mind, send me an email at the email address you see on my screen here, and I will give you the listing that they consider to be a rendering that qualifies for the care management.
Okay.
There's a list of them. So as long as you have a care management team in place and you have someone that's kind of overseeing that care management team and they fit the criteria that I will send you, absolutely you would qualify for those patients.
Okay, great. Thank you.
You're welcome.
And I'll send you an email. Thank you, ma'am.
Perfect. You're welcome.
All right. Bye.
Any other questions? Okay. Well, again, I'd like to just let you know that the email address that's up on the screen here, you guys are more than welcome to make a note of that. Any questions you think of later, you're more than welcome to reach out, and I will get back with you with any of the responses that you're looking for. So I appreciate everyone joining today. I hope you have a great rest of the week, and I hope to see you guys back at another Future Insights. Thank you so much. Bye.
So these are non-face-to-face.